Elda Camacho. I'm one of the Leicester General's ITU consultant, and I'm also an anesthetic consultant, and I'm going to speak about acute pancreatitis. So let's see if it all goes well.
Just make sure it click on that one. Just make sure it moves.
Okay, so this is the first slide, and this is the second one.
Yeah.
Are you seeing the second slide?
Yes, we are. Yeah.
Lovely. So these are the different things we're going to talk about regarding acute pancreatitis. Not going to go through them. I think I'm going to turn off the camera. Are you listening well? Is the voice okay?
Voice is okay.
All right, so I'll leave it like that. So first of all, a quick revision on the anatomy of the pancreas. So there's not much to it. We know that there's a neck. Can you see the little arrow or not? Can you see my arrow moving? No. No, never mind. So there's the head of the neck.
We can't see the arrow.
Yes?
Yes.
Okay. There's the head, that's what we call the neck, that's the body, and there's the tail. And of course, we know that the common bile duct most of the times goes through the pancreas parenchyma to join the pancreatic duct. They get together and they travel until the duodenum, where they deliver their secretions through the papilla. The anatomy is more complex if we think about the surroundings. So this organ is pretty much in communication with almost everything in the abdomen. We have the pancreas in close relation with loads of huge veins and arteries that cross that are very near it, and there's also very close relationships with the GI tract. So the stomach would be here on top of all this, as would be the transverse colon in here. And of course, we've spoken about the duodenum, where it delivers its secretions. And even the tail is closely related to the left kidney, adrenal gland, and to the diaphragm posteriorly. Of course, all this is retroperitoneal. Now, let's do a quick revision on the physiology of the pancreas. So we all know that there's an exocrine function and an endocrine function. The exocrine function is produced by the acini, and as we said before, it drains to the ductal system here. So all the secretions will be drained in here. It contains basically the digestive enzymes, amylase, lipase, and some precursors of protease. So pretty much responsible for the digestion of almost all nutritions. The exocrine function, as you all know, the proinsulin and all the other stuff, glucagon and somatostatin and pancreatic polypeptide, they are secreted in the Langerhans islets that are scattered all around the pancreatic parenchyma. And this is also very important at the cellular level. It allows the slow molecules that were absorbed by the GI to go inside the cells. So the pancreas is very important, is central, together with bile, is central to our digestion and to the feeding of our cells in our body. Now, why do we have pancreatitis? Why do we have acute pancreatitis? Most of the times it's because of obstruction. Somewhere the pancreatic ducts become obstructed, most of the times because of gallstones, sometimes because of masses like tumors, and some other times it's even iatrogenic. So in the effort to try and remove the gallstones through an ERCP, we're going to increase the pressure in the pancreatic duct, and the enzymes that should be activated inside the duodenum are going to be activated inside the pancreas. Alcoholism is another big cause for pancreatitis, and we'll come back to this later. Then there are a myriad of other causes that you can see here, like metabolic abnormalities. If there's a perforated gastric ulcer, we've seen that the stomach is very closely related to the pancreas. If it perforates, it can damage the pancreas and release its secretions where they shouldn't be. Medication, there's a whole lot of medication that can cause pancreatitis. Cystic fibrosis, as you know, these patients have much thicker secretions that can somehow put some pressure on the pancreatic ducts. Trauma, although not very frequent, if there's a blunt trauma to the abdomen that is severe enough, the pancreas can get damaged. And then there's our autoimmune causes and even idiopathic causes that are probably some of the others that we cannot identify. So the baseline of the acute pancreatitis is when there's acinar cell injury. And on one time, it involves intracellular mechanisms due, as I told you before, due to enzyme activation earlier than normal and calcium accumulation, that those enzymes are going to sort of digest the organ itself, but there will be repercussions around the pancreas on the neural system and on the vascular system. And ethanol is toxic itself, so we don't need to have a lesion to the pancreatic parenchyma. Ethanol can do it by itself, and so that's in the cause of the alcoholic pancreatitis. The cause is basically the alcohol. Now, some words about epidemiology. These are numbers from NICE. So we can see that it's significant. We have 15 to 42 cases per 100,000 a year in UK, and numbers apparently are rising steadily. Now, the mortality rate of the disease is considerable, 1 to 7% generally, but it goes up much more higher if the disease is more severe. It could be as high as 60% if it is as severe as giving organ failure. Now, we know that gallstone pancreatitis is more common in women, elder women, and that alcoholic pancreatitis is more frequent in young males. This is probably just a sociological find. Now, about the classification. The classification has to do with the presentation, image presentation of the pancreatitis. Of course, we can have acute pancreatitis and chronic pancreatitis. We're not going to speak about the chronic pancreatitis, but we know that an acute pancreatitis can evolve to a chronic one. So in acute pancreatitis, the simplest form is when it is edematous. And as the name says, it means that the pancreas gets some edema. That's what you can see in the top image in here. So there's some edema to the pancreas. The next stage is if that parenchyma gets necrotic. It's considered worse. And as you can see here, there's this area where there's some fluid, some liquid that corresponds to that necrosis. And the worst case scenario is when that necrosis evolves to erode some small vessels, and then there's also blood inside, and we call it necrohemorrhagic. There's another stage in which sometimes this area of necrosis will be limited by like a wall, and then we call it pseudocysts, and this is important in the management of the pancreatitis, as we will see. Now, about diagnosis. It's nowadays universally recognized that we need to have at least 2 of the following criteria. One of them is a characteristic upper abdominal pain. As you all know, it's the kind of pain that goes to the back. Or we need to have elevated levels of pancreatic enzymes in the blood or even in urine. So the serum amylase or the serum lipase should be 3 times above the upper limit. And there's this dipstick measurement that can be done at a GP level in patients early in the diagnosis of the pancreatitis. And we should have suggesting findings on radiology or imaging, like in ultrasound, CT, or MRI. So nowadays in the UK, the most common is to have a CT that shows us images similar to the ones that we saw previously. Now, the disease, as I told you, can go from a mild disease that can be handled even at home to a very extremely severe disease with multiple organ failure. Very characteristic is the epigastric pain irradiating to the back. It's very common that the patient presents agitated, distressed, and confused. The GI symptoms are very frequent, as you would imagine, like vomiting, anorexia, and reduced oral intake. And the patient might present a picture very similar to septic shock. So it's very frequent that these patients present in A&E and they start the septic shock pathways because it's so similar. Then the abdomen typically is tender, distended. There are reduced bowel sounds and there's some guarding. We'll see the skin ecchymosis in the next slide. And on the thorax, typically there's a basal reduced air entry, and this is because of the close relationship of the pancreas with the diaphragm. These are the very typical signs of necrohemorrhagic pancreatitis, Cullen sign and Gray-Turner sign. Don't expect to see these signs. They are rare and they will present only in very severe pancreatitis. And sometimes we can miss them because they look like the places where we inject the dalteparin subcutaneously. So the clinical presentation, as it can go from very mild to very severe, we are looking at different organs and systems that can be affected. Anyway, the common thing is that there's a sequestration of fluids around the pancreas, and that's because there's a huge inflammatory reaction to the extravasation of those secretions from the pancreas. And this inflammatory reaction turns systemic. It will affect all the body. So as we said, it's very common to have this hypovolemic vasodilation picture with low blood pressure, tachycardia, confusion, delirium. GI symptoms are also, as we said before, very frequent, and we can have GI ischemia if some of the vessels are affected. We can have GI perforation at some point, with GI fistulas, and it could be a bile fistula, pancreatic fistula, or a bowel fistula, and this will mean sometimes generalized peritonitis. We will frequently have a renal picture with AKI, uremia, hyperkalemia, and generalized edema just because the kidneys are not working properly. We frequently have a respiratory picture, and when we're talking about ITU, probably this is the most common cause for admission in ITU, hypoxia and type 1 respiratory failure. But hypercarbia is also common, as pleural effusion, mainly on the left, again because of the proximity of the tail of the pancreas. And this pleural effusion can get infected. And this could be because of a pneumonia that appears later. And pneumonia itself is not a direct result of the pancreatitis, but could be because of the limitation of ventilation because of the splinting of the diaphragm, or could be associated to the ventilator because at some point these patients might need to be intubated and connected to mechanical ventilation. And this pneumonia could infect that pleural effusion. We could have vascular features also, again, because of increased permeability and vasodilation with edema, but we can also have erosion of mesenteric vessels or other vessels. And we've had before cataclysmic hemorrhage because of this kind of phenomenon. Neurologically, well, the very general signs and symptoms, most of them related to the hypotensive and ITU, like agitation, confusion, and delirium. And of course, we can and frequently have a critical illness myopathy, not because of the pancreatitis, but because the patients stay very long times in ITU and they don't move and so develop this problem. Now, about severity scores. I'm not going to speak a lot about these. The most classical ones are the ransom criteria that are quite old now, and they appear to assess the severity of alcoholic pancreatitis. And they were modified later to assess the severity of gallbladder pancreatitis, lithiazic pancreatitis. They use these different markers, parameters, and they achieve a number. And in medicine, we love to have numbers. And so this would give us the predicted mortality, which we love to know. But in fact, they are very limited. So these numbers are collected after 48 hours of admission. So for the intensive care, this is really not important for treatment. They're not very sensible, and they're not very specific. And there are several studies that say that they're not proper to evaluate some populations or even places with a high altitude. After these ransom scores, there are several other that are very similar, like the BSAP, the Glasgow, and modified Marshall. But to be honest, a simple score as APASH-2 that is not specific for pancreatitis at all and will have a broader number of parameters will probably be better to give us an idea of the severity and thus the mortality of the patient. Now, about treatment. This was taken from a relatively publication in The Lancet. In the past 10 years, the treatment of acute pancreatitis has moved towards a multidisciplinary, tailored, and minimally invasive approach. So more important than knowing specific parameters about the patient is to know more things about the patient, comorbidities, other characteristics of the patient like obesity, things that could be important in assessing severity. And then more and more, the surgical treatment is less invasive, and that has increased survival significantly. Anyway, despite all these new approaches, as we've seen, the pancreatitis, acute pancreatitis, is still associated with the high mortality rates when when there's organs involved. Now, in a general basis, what we do, we have to give patient fluids, and this should be goal-directed, and we should use balanced IV solutions, and sometimes we have to give blood products if the patient needs. Then nutritional support is very important. So after 72 hours, we need to start feeding our patients, and we've seen that the pancreatitis will affect all the nutrition, not just the absorption in the GI, but also the cellular nutrition. Then, this is very general. We have to give maximal support care in ITU for any organ failure. And in here, this could be a manual of ITU care. So we have to deal with whatever strikes the patient, whereas it's in the kidneys, in the heart, or the GI, or the lungs, and ventilation. Now, more and more we understand that there's no roles for prophylactic antibiotics, because acute pancreatitis is not an infection to start with. Yes, we should give antibiotics only when we have proof that we have a complication, and it's very frequent to have infectious complications. We know about pneumonia, that is quite frequent as soon as the patient is connected to the ventilator, and some of the collections inside the belly of the patient could become infected, and in that case, only in that case, we would need some antibiotics. And antifungals. We know that any critical patient is more prone to have fungus infections. Now, about the surgical approach. So again, more and more we do minimally invasive surgical approach to these patients. And I remember 20 years ago, these patients would be having a laparotomy, and the surgeons would take something like mud from inside the patient, leave it very clean, and the patient would die. So more and more what we try to do is, if the pancreatic ducts are obstructed, we try and go there doing an ERCP and disobstruct whatever is obstructing them. And then in necrotizing pancreatitis, we only intervene when that fluid has already sort of a wall. And when that happens, we call it pseudocysts. And that's when we should drain them. And it can be done per percutaneous ultrasound guided drainage, or through the papilla, and that would be very similar to an ERCP, or we can do an endoscopic gastrocystostomy, and we're doing this more and more. And this is very convenient because we know that the back wall of the stomach is very near the pancreas. So if we do an OGD and we perforate the stomach, it fall inside the pseudocyst, we can even put a stent in there, allowing the drainage of that content directly into the stomach. And it allows us, the gastroenterologist, to go back again and to do some washout of that pseudocyst. And of course, we can use a laparoscopic drainage. I would say this is the last resource because it's more invasive than the previous one. But if the pseudocyst is not accessible, the surgeons can do this also. Now, prognosis. As we've seen with the Ransom criteria, the severity of the pancreatitis is closely related to the mortality. So the more severe, the higher the mortality will be. Then, even after the resolution of the pancreatitis, there can persist some impaired exocrine function, and the patient might be having to be supplements of digestive enzymes. There could still persist a certain glucose intolerance would be impaired, and exogenous insulin could be required. Very frequently, acute pancreatitis is recurrent, especially in alcoholic causes. And it could evolve to chronic pancreatitis, again, mainly in alcoholic causes. And this could be related to the ongoing aggression to the pancreas. What we know is that the quality of life scores tend to worsen after an acute pancreatitis. And in severe disease, we really don't know if this is due to the pancreatitis itself or due to prolonged ITU stay. But it's a fact that the quality scores of life decrease after this disease. Now, we could ask ourselves, in pancreatitis, less is more, and it looks like so when we look for the surgical approach over the years, definitely doing less, waiting until a certain phase of pancreatitis has proven to improve the survival. But when it comes to ITU, these patients have multiple ITU admissions during the course of the disease. They normally have prolonged lengths of stay in ITU. The mortality remains high in severe disease. And in ITU, we potentially have to support every organ and every system. We may have to use all ITU resources, skills, techniques, and knowledge. So acute pancreatitis is still an ongoing challenge for the intensivist. I leave you with some references, and I also leave you with Ravi that is going to moderate the discussion. And of course, I'll be here for any questions or any queries. Okay.
Good. Thank you, Dr. Kamako. That was a detailed presentation on acute pancreatitis, which to me is like the prototype of a general intensive care patient with multi-organ failure. Any questions? Just looking at the chat as well. Well, I have one question on a patient with acute pancreatitis. Can you hear me?
Yes.
So this issue of these patients being in the ITU for months and months together, I think that becomes the main problem. And I have at least seen few patients who've stayed in ITU for 4 or 5 months, and they keep going into multi-organ failure, recover, and then improve a bit, and then fall off the perch quite rapidly. How should we go about decision making in terms of managing these patients with supporting their organs on an ongoing basis? How long is long in acute pancreatitis?
Well, as everything in medicine, and more, we should customize this to each patient. So we have to look at our patient and see how far we can go. If we have a very frail patient, elderly, and with almost no reserve, we know that after a certain number of attempts or interventions, that the patient is not going to do it. But it all depends on the assessment that you do to the patient. And sometimes what is very common in acute pancreatitis is we come to a point in which the patient is good enough to be discharged to the ward, and he goes to the ward, stays there for sometimes for weeks, and for some other complication they bounce back to ITU, either because they get infected with the pneumonitis or because the pancreas becomes more swollen, or because the collection that's still in there gets infected. Yeah. So it's very difficult to respond what to do, because each patient is a different case and it has to be done individually.
Okay, thank you. I think Kaya's got a question.
Go on, Kaya.
Kaya?
Hello, everyone. I mean, I think not so much a question, but a reflection. I remember when I was doing, when I was a student in Poland, I remember the patients with pancreatitis on the, on the surgical and wards and on intensive care. And the surgeons were doing exactly the same as you, Dr. Camacho, described. Those patients were regularly going to theater for a washout. I think there was a trend of actually putting draining and the drain pushing the fluid in and now trying to washing out that inflamed fluid, but they've all been essentially dying, I think, faster than actually not interventional procedure. And it's quite interesting because it's another diagnosis that it's surgical and it's more and more managed medically.
Exactly.
And there's lots of things like that we are pushed from the acute surgical management, when the surgeon could go in and do some intervention into the very frequently prolonged management by the actually more medical team than the surgeons. It's just an observational thing just to share with everyone. Thank you.
Exactly. And more, I think this trend goes not just for acute pancreatitis, but for all surgical, let's say, problems, abdominal problems. And more we see that, for example, GI fistulas, for some reason, more and more they are approached conservatively, I mean, the patient will stay in hospital a long time, but at least they're not going inside the belly and doing more damage, because, after 1-2 operations, all the bowel is just falling apart. And instead of 1 fistula, they will have 2, 3, 4 fistula. So this goes not just for acute pancreatitis, but probably for more problems, abdominal problems.
Yeah. And I think the endoscopic cystogastrostomy with a stent, I think that's changed a lot in the management of these patients, especially when they're in intensive care for months together. With a stent in place, the gastroenterologist can go in repeatedly whenever they want to do a washout.
Exactly.
Yeah, thank you, Dr. Camacho. If there are I think Joanna wants to ask. Go ahead, Joanna.
Hi. It was just a little question, really, from a DART point of view. So a lot of these pancreatitis patients at the general end up having multiple readmissions to the unit. Is there anything that you can think of that we could be doing better out on the wards to support these patients?
I think DART does an amazing job in the wards. I think overall this is one of the characteristics of the disease. What we can do in the ward is make sure that the patients are mobilized so that they have less risk of having an infection to the lungs. Make sure that they are getting the right support, nutritional support. Make sure that they have the right amount of fluids and that the kidneys are working properly. And that's it. And if they start having some sort of infection, that we start antibiotics early. And there's not much more that can be done in the wards. And I think DART helps doing that whenever the patient is getting worse. But I think you are doing a splendid job already. So I don't think there's anything else you can do, to be honest.
Thank you.
Absolutely. Any more questions from the audience? If not, we can move on to the next section of the teaching, which is the journal club.
Thank you very much. Thank
you, Dr. Camacho. Thank you. Okay, so the journal club section this week is on the NICE sugar trial, which is a landmark paper. It's going to be presented by Seham, who is one of the ST3 anesthetic registrars. Over to you.
Okay, thank you. Hello, thanks everyone for joining us today for the Journal Club. I hope you can see me and hear me well. Okay, so today I'm going to talk about the NICE Sugar trial, which, as Ravi was telling you guys, is a very important trial and landmark trial. So it's basically regarding blood sugar control in critically ill patients, and this is the journal article here. So basically, glucose is pro-inflammatory, pro-thrombotic, and pro-oxidant, and how, you know, differences in the glucose level can lead to increases in the length of stay of the patient, increases in infection and overall complications, and of course severe hyperglycemia is associated with increased morbidity and mortality. So this trial was done to look at how glycemic control in critically ill patients affects mortality and morbidity. So the main question was, how does intensive control, which is keeping the sugar between 4.5 and 6 millimoles per litre, compared to conventional glycemic control, which in this paper was less than 10 millimoles, so between 6 and 10. And this was to see what was the optimal range of the blood glucose level in critically ill patients, and if you intensively control blood glucose, does this reduce the mortality at 90 days? Okay, so the study design, it was a parallel group randomized control trial, and it had medical and surgical patients admitted to ITU in these years, December 2004 and November 2008, and they were expected to need ITU treatment for at least 3 days or more, and it was done in 42 hospitals in Australia, New Zealand and the USA. So 40,000 patients were screened, 6,000 of them were recruited, and to be included, they had to be in the ITU and require 3 days or more of ITU care with an arterial line to allow easy blood sampling for the glucose. And the criteria, this was kind of concomitant kind of data. They were excluded if they were admitted for DKA or HHS, or expected to be eating by 3 days, or very high risk of hypoglycemia, such as insulin secreting tumor or liver failure. And then they were randomly assigned to one of two groups. So there were two groups. There's a difference between the measurement, but basically there's a tight control group where the blood glucose was tightly monitored and controlled between 4.5 and 6. And then the insulin was administered to keep the blood sugar always less than 6 millimoles, and it was titrated to the blood glucose. If this fell below 4.5, then they were administered glucose level. And then the conventional control, basically they were just trying to keep the glucose below 10, and insulin was only administered if the glucose exceeded that, and then discontinued when it was less than 8 millimoles. So the way that they did it was they used intravenous infusion of insulin in saline, and then once the patient was eating and discharged from ITU, they discontinued the intervention, and then they resumed the same protocol if the patient was readmitted within 90 days, and then this was discontinued 90 days afterwards, since randomization or death. And then they tried to get the glucose from arterial line samples if possible, and measured in the blood gas analyzer. So these are all of the data that they collected. So it's demographics, glucose measurements, red blood cells, if they had positive blood cultures, because that could affect the amount of glucose that was in the blood, the type of nutrition that they had, how unwell they were, and whether they were in mechanical ventilation or renal replacement therapy. So the main primary outcome was looking at the death from any cause within 90 days of randomization, and then they had some secondary outcomes, which was survival at 90 days, how they died, and duration of mechanical ventilation and renal replacement therapy. And they also then had another tertiary outcome, which is death from any cause at 28 days after randomization. And you can see other things that they've also collected here. So they initially aimed to recruit 4,000 patients, and then they had then increased it to 6,000 patients to make sure that they had enough statistical power to be able to see if there was any statistical significance. And the data was all analysed with the intention to treat principle. So they looked at this primary analysis using chi-square test, and then they also used other endpoints as well with chi-square test and Fisher's exact test. And then this is just the statistical method that they used to kind of derive their values. And then after that, they had a Kaplan-Meier curve, which we'll look at afterwards to discuss the results of this trial. Okay, so this is just a brief overview taken from the paper. So 6,000 of the patients underwent randomization. You can see that there's quite equal split between the two groups. There's 3,000 in the intensive glucose control and 3,000 in the conventional glucose control. And then basically there was few dropouts, which you can see the reasons why they were dropping out. Sometimes the patient would withdraw their consent, or they were switched to palliative care, or they had adverse outcomes. But overall, the number of patients in both arms are fairly equal. And then this is basically the data, and you can look at the baseline characteristics of the two groups. So they were very comparable with the intensive and conventional groups. The age was very similar. About 60 was the mean age. About 62% were male. Patchy scores were similar. Operative admissions were similar, and the length of stay was also similar. Okay. So then the patients who were having intensive glucose control were more likely to have received insulin, which will be quite self-explanatory. And they received a much larger dose of insulin because their glucose control was expected to be much more tightly regulated. And the mean time weighted blood glucose level was 6.4 in the intensive group rather than the conventional group. So here you can see basically in the conventional group, they had a much higher glucose level in the blood compared to intensive glucose control. So giving insulin did reduce the glucose level. And then here again, this is another picture which shows exactly the same thing. The intensive control had a much tighter control over their glucose levels compared to the conventional control group, which is what is expected. And of course, the mean is lower in the intensive control group than the conventional control group. So the primary outcome for this trial did show that there was a statistically significant difference at 90 days mortality, and it favored the conventional group, i.e. there was a difference in mortality, and the odds ratio for the death within the intensive group was higher than the conventional group. Okay, so that's what it's saying. Difference in mortality is still significant, even with the adjustment for the baseline factors. And the causes of the death were mostly cardiovascular causes, which were more common in the intensive control group rather than the conventional control group. And here is the Kaplan-Meier graph. And as you can see, with the conventional glucose group compared to the intensive glucose group, there's a higher probability of survival for the conventional group, glucose control group. And that is statistically significant difference. Okay, in the secondary outcome, they also found that there was a higher incidence of severe hypoglycemia in the intensive control group compared to the conventional control group, but there was no difference in their mortality at 28 days, median length of stay, organ failure rate, and number dose mechanical ventilation or renal replacement therapy, and the rates of red blood cell transfusion or positive blood cultures. Okay, so the main conclusion for this paper is that we should target a blood glucose level of less than 10, resulting in a lower mortality than a target of 4.5 to 6. And they do not recommend that we use a lower target in a critically ill adult. For most units, we do look at targeting the blood glucose level between 6 and 10, and this is why we do that in most units. The strengths of this were that it was a well-designed study, pragmatic, it had a clinically relevant research question, they did have a good amount of participants in there, they had enough power to be able to show a statistically significant group as well, and they were all, you could see that there was a difference in the glucose levels for both patient groups, and they were administered correctly, the management based on the algorithm and which group they were assigned to. Some of the weakness of this is that some of the patients did prematurely discontinue the treatment, and that was normally due to the physician decision or change to the palliative care, and this may have introduced bias because the clinicians were unblinded. Okay. Other things that might have affected is that in the intensive control group, they did receive steroids as well. And this may affect the measured outcome because that can affect the glucose level, but it's not very easy to kind of prize apart how this would have affected the results. Okay, so the other thing we need to know is that we did the median blood glucose for the intensive control group was 6.4, which was higher than 4.5 to 6, and it did still show that there was an increase in mortality for this group of patients. Most of the patients as well received their nutrition via enteral feeding routes, so it might be difficult to kind of extrapolate to TPN, for example, for these patients. And as I said, in the secondary outcomes, there was no change at 28 days. So they haven't actually tried to say why there's no change in mortality at 28 days compared to 90 days. So why is this a late kind of effect on the survival? So yeah, thank you very much for listening. If you've got any questions, please let me know. Please also complete the feedback either by clicking on this link or by scanning this QR code. And if you've got any questions, please let me know. Thank you.